From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine, and I'm here at the American College of Cardiology meetings in Chicago, and I always use these meetings as a chance to catch up with friends, colleagues, and talk about something that's really in the cardiovascular news. Today I'm really fortunate to be with my good friend, Dr. Jeff Kuvan, who is the chief and professor at Northwell in New York. So thanks for joining us.
Thanks, Bob. Great to be with you.
You are the perfect person to have this conversation because you've really been out in front trying to help all of us in this notion of maintenance certification, training for cardiologists, lifelong learning. But I want to go back earlier, and we'll eventually get to cardiovascular boards, et cetera. But what I want you to actually help me and help our audience think about, Jeff, is how do we educate, train, and maintain education for cardiologists of the future? You and I are from the previous generations.
That's right.
And but you know, before we came on screen, I was talking to you about a mutual friend, Joe Green, who had been at the American College of Cardiology for many years. He's very big in the CME world. And Joe once showed a graph that showed undergraduate medical education, 4 years, 5 years, graduate medical education, 5, 6, 7, 8 years, CME, 40 years. And he said all of our attention's on the first two, not the last one. So give me your broad view of what cardiologists, how we should be training them, not so much what they need to know, because that's going to change, but how we should be educating them, training them. Why don't you start out?
So first of all, thank you for having me, and I can't think of a more topical issue to discuss. So important to teach the next generation how to be clinicians, how to be competent cardiologists. And I think you said it, this is a lifelong journey. You don't finish your education in the pre-medical world or even after graduate medical education. We're never done being educated. We're never done learning. But we need to know what we know, and we need to know how to address the issues we don't know. We need to be involved in our own education and embrace it. This is good. It shouldn't be a punitive approach to education. So we have to embrace the concepts that we need to continue to learn, but how we teach and how we learn is evolving. The way you and I learn through textbooks and lectures, it doesn't exist anymore. The generations now have grown up with cell phones and computers and now AI. How do we incorporate all of these into our educational offerings? I think we don't know the exact answer, but we need to engage our students. We need to engage our lifelong learners.
I was in a session yesterday at the convention center on harassment in the workplace. And you'll see the relevance here, that one of my colleagues made the comment, well, we have so many generations in the workforce. And then it made me think, yeah, I think about my own place. We have people in their 20s, we have people in their 80s, and everything in between.
That's right.
They learn differently. And we, people like you and I who are interested in education, really have to be able to accommodate that, don't we?
First of all, students and graduate medical education trainees are smarter than they've ever been before. But it's how to incorporate the knowledge. Remember, knowledge is what we know, but it's the application of knowledge. How we actually translate that to the patient, that's competence. So how do we make that bridge from what you know in your brain or what you can find out on your phone to actually taking care of patients and ultimately affecting outcomes of patients?
You know, I love the way you said that, because what we know is going to change. And the listeners have heard me say over the years about Dr. Stead, Gene Stead at Duke, who formed the Duke Data Bank, for example. Very visionary thinking. And about education, he used to say, never teach anything that you can look up. He said this in the 70s, when looking things up was not that easy. But today, you've said it. I mean, we've got AI. We pull out our phone and look something up. You know, on rounds it used to be, why don't you look that up and on Friday give us 5 minutes about that? If somebody can look it up and give you 5 minutes on it right now.
That's right. And our patients are demanding it, right? Our patients know a lot more than they used to know. And I would also argue it's not just about answering a test question, medical knowledge. It's about the other competencies. Are you professional? Can you communicate? Can you work in a system of medicine? And the system of medicine is getting so complicated. We need to teach that, and then we need to make sure that people can adapt to changes in medicine. Every single day, as you know, and as we practice, it is different. Yeah. The medical world continues to change.
I mean, just think about a meeting like this. Things that we learned over the weekend we're going to go ahead and do them next week.
That's exactly right.
Now that I have the opportunity to oversee a medical school, I've been thinking a lot about medical school education. And somebody asked me, well, what do you want the medical students to know? I said, that's not my job to see what's in the curriculum, that's the broader faculty job. But what I'd like them to know, or what I'd like to convey to them, is to love learning and to really see life, I like the way you said it, Jeff, as a journey for those of us in a profession where it's lifelong learning. And how do we, over time, continue to find ways that excite us about learning?
That's right.
You know, people may, my age, I still read journal articles. I still look at, lectures and try to understand, like, what's the latest and the greatest. But I will find that as there's so much information, I want it in chunks. I want little bits of it. And people are always amazed. I say, how do you keep up with the literature? I say, through social media. I follow all the journals.
Right.
I look at the journals online, and I follow what I say are people who have good taste in science. Eric Topol, Harlan Krumholtz, they have great taste in science, and they tend to summarize things in a way that I look, I go, what? I didn't know that's an interesting concept. Boom, download the article that they're referencing, read it later.
That's right. With the exponential rise in information, you can't know everything. It's about synthesizing bits of information and then being able, as I said, to apply it to our patients, or to apply it to your research, or to apply it to a population.
Well, let's get practical. On your leadership journey, you used to run a fellowship program.
I did.
And one of the things I hear from fellows is, can we do something to shorten the length of time of training? Now, I'm also a former internal medicine chair who really thinks that our training as internists is really important. But how much of that do they need before they go into cardiology? I think of internal medicine as a way of thinking. And I think all of us who trained in internal medicine, the whole notion of the differential diagnosis and honing in on what the patient has through the collection of information is a very useful construct. We're the profession that actually thinks like that. What's the average fellow stay around for now?
3 to 6 years?
Yeah, it's a long time.
It's a long time, and I think that's significantly affecting our workforce, and there's been a lot of discussion about that, actually more recently than ever. We clearly need to change the paradigm of training. It hasn't been changed in a very long time. We've added more years, but we haven't synthesized actually what has to happen during training. And I agree, medicine teaches you holistically about the patient, and I wouldn't change that for anything. But do we need 3 years of internal medicine? And by the way, what is a year or 2 or 3? That's a time, and it's very different for everybody. We really need to change, as the ACGME wants us to competency-based assessment. And everybody is different on their journey. Some may develop competence after 2 years. Some may need 4 years. That's hard for a chair of medicine to figure out your workforce.
It's hard for a residency program. Like, how many interns do I have to accept next year?
Correct, but we need to adapt.
Yeah.
And we need to make sure that, number one, our trainees are learning, but number two, that they can figure out how to get to the end result, at least the beginning of their career, in the appropriate amount of time, but more importantly, do they have the competencies to do it? So if you think about it, when we trained 30 years ago, that hasn't changed. In fact, it's gotten longer. We've tried in various ways to short track, to figure out ways of combining maybe the third year of internal medicine, but we really haven't addressed it, while others in our field have. Thoracic surgery, you can go right from medical school into thoracic surgery, vascular surgery, urology, dermatology, neurology. So we need to think about what is best for cardiologists. And I would say there's not one solution. There need to be multiple pathways.
Yeah.
If you would like to be a structural heart physician, well, perhaps you go right from medical school into cardiology, intervention, and then structural. It takes 4 to 5 years. But at least you've shortened the entire duration of training. If you want to be a general cardiologist or a heart failure specialist, perhaps you need 2 years of internal medicine. We have to be flexible, we have to think about the workforce of the future, and we have to address this.
I like what you're talking about conceptually, competency. When I talk to my surgical colleagues, they agree that they really had to do this, get them right into the specialty that they're going to practice. But they also lament that they've lost those general surgical skills. That if you've only spent your time, for example, operating in the chest, if something happens in the abdomen while you're in the operating room, it's a little different for a young surgeon than a more senior surgeon who may be trained 4 or 5 years of general surgery, then their subspecialty. And I think structural is a good idea. Like when I was a fellow, I don't think we used the term structural heart disease. You could do extra training in those days in valvular heart disease, but did we use the term structural? And
Not
what
at
are we
all.
going to use in 20 years? And what if you're a structural cardiologist and that field goes away?
That's true. That's true. I think we can form more general physicians and we can form more specialists. Whether we like it or not, the world is becoming more and more specialized.
Yeah, I
You're
agree with
becoming a left atrial expert or left atrial appendage expert. You're right, that field is going to change or other fields are going to change, but we need to have different pathways for different people.
Yeah.
We just can't be stuck in a model where it has to be this, 3 years, 3 years, 2 years, because we're going to lose our workforce.
When I was an interventional cardiologist in the cath lab, when the fellows would start, you know, they all did a year, right, in the interventional lab. And this was when I was at Duke. And early on, you'd get anxiety, like, am I going to be able to learn this? And I said, look, I've been doing this a long time. There'll be a group of you who in 3-4 months are really good at this. There'll be a group of you who in 6 months are really good at this, and there'll be a group of you that take a year to really get your skill set down.
Right.
And that's okay. You know, we make everybody stay a year in that particular case, but maybe we shouldn't have. Maybe the person who at 6 months knew what they were doing was ready to graduate.
Right. And I think it's also important to understand, as you said, as we started this program, it's a lifelong journey.
Yeah.
You don't finish your learning at the end of your training. In fact, I would argue that's when you actually begin your true learning, your experiential learning. So that's the importance of early career mentorship, of having people that you work with that can help you along the way. And staying in touch and staying involved and understanding as to what you know and what you need to actually brush up on.
Do you think that when you leave medical school, you're ready to make the decision that I want to be a structural heart cardiologist?
Well, we've seen it in other areas. You know, I think recently in the match, people are going right into anesthesiology, right into thoracic surgery, right into fairly narrow areas.
Yeah, right into yeah, you're right.
And for those who don't, then I think absolutely there should be an option to go into 3 years of internal medicine, figure out what you want to do. We need to just be more flexible.
Yeah.
And our world and our trainees are actually demanding it.
How do you do that from a competency testing perspective? And how do you do that? We're going to get to the issue in more detail, but how do you do that from a board certification perspective?
Yeah, it's tricky. It's very tricky, and I think we're not the only ones thinking about it. I mentioned the ACGME. They would love to figure out ways of truly assessing competency. I think it's building a portfolio of evidence that says, you know what, I can have the medical knowledge that is then translated to patient care, but we can do it in very different ways. In my mind, it's not just taking a multiple choice test.
No, I agree with that.
I think that is old school thinking, and I think the world has recognized that. It has to be skills-based, it has to be simulation-based, it has to be the understanding of how to synthesize medical knowledge and then figure out how to translate it. It has to be much more holistic, right? We're living in a totally different world where even if you have the medical knowledge and you can't go into the world of the 6 competencies, you're not going to be an effective physician.
You know, it's interesting, the surgeons from an old school perspective have always held on to the oral exam, right? For surgeons, it's like a rite of passage.
Right.
That they spend those times being quizzed by their seniors as to how you might approach a medical problem.
Right.
And maybe what's old is new again, is that we could design systems like that
Correct.
to test competency.
Correct. And using technology.
Yeah.
You know, I think a great way to think about it would be in simulation, where you're not working on a patient, you're working on a model, but now with tools that we've never had before, you can actually test one's knowledge, but then their application of knowledge, and hopefully not hurting anybody.
I'm thinking a lot about medical education these days. What do we do in medical school? Because in some ways, medical school really has to be thinking differently. That, you know, this notion that you get the foundational sciences, then you move to the clinical sciences, then you move to the application of all of that, is limiting us in terms of how we think about it. And there's a certain amount of foundational science you have to be a medical doctor. And we're actually hopeful that some of them get the spark of like, well, that's what I want to do. I want to be a laboratory scientist.
Right.
How do we design medical education in a way that fits this new paradigm?
I think it's a great question, and I'm proud to say at the Zucker School of Medicine, where I practice, I think they're moving the needle. Before the students start their training in medical school, they become EMTs. They are thrown into the world.
Is that right?
Absolutely. They're thrown into the world of actually clinical medicine.
Yeah.
And clinical medicine is integrated from even before day one. In addition, there are no lectures. It's all problem-based learning, problem solving, and integrating the physical nature of anatomy, but thinking at the same time, how is that going to look on an ultrasound or a CT scan? And then under a microscope. It's integrating all this information, applying it, and then having them think clinically.
Let me ask you a question around that. How have the senior faculty adapted to that world of not giving lectures?
Well, the good news about the medical school where I work at, it's only 15 years old. So there aren't that many
There's
senior
not that
faculty.
many folks who've been around for 40 years.
That's right. But at the end of the day, the outcome is the same as other medical schools.
Yeah.
Their scores are really good. They're excellent clinicians, but they understand the fundamentals of clinical medicine very early on.
Yeah.
So I think blowing up the concept of 2 years basic science and then 2 years clinical, that's first and foremost. Integrating and really teaching people how to think.
Yeah. Yeah, that's the thing that I've been interested in, is how to teach them how to think, how to teach them how to learn. And, you know, we all learn differently. I've learned in my own career that I'm a visual learner. It may be why I became an interventional cardiologist. It may be something that I learned as an interventional cardiologist. For example, I have a hard time with audiobooks because I get distracted. I have to read a book. Right. And I've learned that that's my learning style. So I say, okay, that's my learning style. If I'm going to do something, I want to look at it on the page and flip through it. With younger students today, or younger trainees, do they come into this with different learning types?
100%. Probably things that we haven't even imagined.
Yeah.
I think what I've learned is there's a lot of visual learning. There's a lot of chunked learning. Yeah. They're not going to sit down and read a chapter in a book. It has to come in small bits. I think there is certainly learning by experience and thinking more pragmatically about problems. How do we solve a problem? How do I get the information? Not that I have to know the information. How do I get the information, understand it, and then apply it? So that's the way I think we need to move. And if we're going to be sort of stuck in the past, we're not going to be training the physician of the future.
Let's talk about the fellows now. Can you have a fellowship program, everybody on different tracks? And you know, you rotate. We historically have rotated them through general cardiology, imaging, prevention, you know, the cath lab, et cetera. How do you see that evolving?
I think similar to what's evolved in medicine, where you sort of think about it first like a smorgasbord. You have to tap into what it's like to be a general cardiologist, what I need to know for the fundamentals. But I think earlier and earlier, deciding what you actually want to do and focusing on that. I don't think you need 3 years of general cardiology training. And we've learned that over the years. Now we've actually gone backwards. 2 years of general cardiology, 2 years of electrophysiology. We should move the needle even further for people who know that they want to do certain specific skills.
If I think about my own training, I did 1.5 years of clinical cardiology, which included the cath lab. I did 1 year of interventional cardiology. That's only 2.5 years. Okay. But then I spent almost 2 years as a research fellow in what was then the Duke Databank. I spent 1.5 years as a research fellow. How do we incorporate all of that?
Well, I think, again, you have to ask what does the individual want to do? And that's great for some individuals who want to be physician scientists or clinician scientists. Others may want to go right into practice. I'm not saying that research isn't important for everybody, but I think you can dial in and dial out, but it has to end up being a flexible environment. And as a program director or a chair, we need to understand the flexibility of our trainees.
I was involved with one of the earlier versions of the ACC's competency documents for residency, for fellowship training, and I was responsible for the research chapter, and we actually ended at the point that you just said, which is all of us need to have some understanding of research so that as you're learning, you can pick up an article and understand how does that apply to my patient. And because I agree with you, I mean, we don't have to train, everybody doesn't need a research year.
Correct.
But for the people who are going through training into practice, they should at least be exposed to research in a way that, how do I apply this research to my practice? If you think about what we did over the weekend, as we listened to somebody present, you want to know, was that an important question? Were the methods that they used to address that question good ones? Are the data seemingly reliable, and how do I interpret that data?
That's right. And I would add to that, in addition to understanding the research aspects of medicine, you also have to now understand the business aspects of medicine.
Yeah, let's talk about that.
We need to do a much better job at training our fellows. Systems-based practice, how do I run a practice? How do I deal with RVUs or the world we live in, venture capital? We need to understand, and we need to teach our trainees the ever-changing world of medicine. And in cardiology, it's changing at light speed.
I did a podcast, some of my listeners will recognize, a few months ago on private equity in cardiology.
Correct.
And this is coming, and well, not coming, it's here.
It's here.
There was a whole session over the weekend on private equity in cardiovascular medicine and cardiovascular practice. Yeah, it is amazing when young fellows join the faculty, for example, at all 3 places I've been, Duke, Stanford, and now Weill Cornell. The level of business understanding is very variable. I didn't understand it until I got much later in my career and was responsible for, like you, running the business.
Correct. It's super important, and I think that is an area where the ACC and other organizations can actually help our program directors, give them toolkits because the world is changing very, very quickly. And I don't understand all of it, you don't understand all of it, but we need to work together collectively so we can prepare our trainees to enter a world that continues to change.
Yeah, and it is amazing the number of things that we really want them to be competent in, and how do we teach them that? How do we hold them accountable for that? How do we test that, which gets to my final topic in the last couple of minutes. The ACC, the AHA, other cardiovascular societies have been very interested in creating a new board certification process for cardiologists. Talk a little bit about what the vision was.
So the vision was and remains that cardiology has evolved into its own specialty. We know that. We're here at the American College of Cardiology. It is a world unto itself. We have practice guidelines, we have competency statements, we have all the tools, and we've had an evolution that has been like none other within internal medicine. So the time is now to really think about cardiology as its own specialty. So what better to do than to govern a board by cardiologists for cardiologists? And by the way, when I'm talking about a board, I'm not talking about a testing organization. I'm talking about a board that would oversee lifelong learning from the beginning.
When they enter fellowship, or right when they enter residency?
Before,
okay.
When they finish medical school. What do you want to do? And let's help you on your journey. Let's begin to build a portfolio. You can go one way, the other person can go another way, but you're building evidence that you are competent to then go into training and then become a cardiologist. This is long overdue. Cardiology has been part of the ABIM since 1941. So I'm really proud to say that really for the first time, these societies that are the leaders in America came together and said, this is valuable for our profession. And to make a very, very long story short, we submitted an application to be the 25th board of the American Board of Medical Specialties. The application was reviewed for about a year and a half, and we just learned that the application was denied.
And without getting into, as you say, all the details, what were the key issues of why it was denied? Because I've read different versions of this.
So the key issues are fundamental to the ABMS and the ABIM. Are they ready to subspecialize internal medicine with carved out boards for subspecialties?
Because cardiology will only be the first, and I can tell
Correct.
you oncology will be a quick follow.
Correct.
GI, hepatology will follow.
Correct. So we went into this eyes wide open, that this would be paradigm changing, not just for cardiology, but for the world of medicine. And at the end of the day, I'm not so sure the ABMS was ready for that drastic change.
Did they give you a way to keep the conversation going?
So by their bylaws, they suggest that we can resubmit after 2 years, not before, but after 2 years. So our board is considering that. But I think that given the groundswell of interest for change, we need to think beyond the ABMS. We need to think about alternatives. Because I can tell you that being here at ACC has reinforced to me that cardiologists want to change, not in 2 years, they want to change now. They demand a change now. We've talked about all the things that have to change. These things are going to take time.
Do we have the pieces in place through organizations like the ACC, like the AHA, to be able to get that learning portfolio and assess competence over time?
We do. We do. There are ways that we can actually craft a lot of what we talked about. Getting credit for what you already are doing, really important. Why are we doing all these things at our hospital, within the organizations in which we work? We're being assessed all the time. Most importantly, what's best for our patients? We have to think about the patients and the public first and foremost. And
that is what a board's supposed to do, right? The certification process is not to hang on your wall, but it's really to tell the public that some accrediting body has said, you, Jeff, or you, Bob, have a set of skills that make them capable and competent of taking care of you.
That's right. We all want to go to a cardiologist or a physician that is competent.
Right.
But we have to rely on others to say that person is competent or not. And as we have discussed, and has been discussed in every situation, competency is not filling out a multiple choice test. I'm not saying that questions aren't helpful to assess your knowledge and, more importantly, your knowledge gaps. But it's what you do thereafter that's the most important. How do you fill the knowledge gaps? Where are the resources to support you as a lifelong learner? And to make sure that you're actually understanding, have access to information, and again, applying it to your patient.
I've taken the board exams multiple times over the years, and I always ask myself, look, I'm an academic cardiologist with a fairly narrow scope of practice. It's largely focused around coronary disease, and I'll call it prevention and some of the affiliated consult questions that get asked around that. But I'm like being asked these EP questions that, well, I don't know where in the heart that might have emerged, and is that important for me to do? And I've really struggled with this. Or the other one, whenever I've prepared for the board exam, I really have to do a deep dive in two areas, electrophysiology and congenital heart disease. Like, why?
Correct. So, we need to make things much more tailored to your specific practice. I've never met a cardiologist who says, I don't care about my competency.
Yeah, not ever.
Cardiologists want to maintain competency in their areas of practice, but they need the tools, and it has to be and it should be a supportive environment. We're adults. We're lifelong learners. We need to know what we know. We need to know how to get information about the things we don't know, and then we need to sort of prove in a way that we are competent.
I think in another specialty, as I said, I was the chair of medicine at Stanford, and we had a group of hematologists who do bone marrow transplantation. It doesn't have a formal board exam like HEMONC does.
Correct.
But we would hold them, our health system would hold them accountable to be board certified.
Correct.
So here are people who have a highly specialized set of knowledge in BMT. And is it really the best use of their time to make sure that they can pass either the oncology boards or the hematology boards, which are related but not really what they do every day?
Correct. You need to understand how to recognize certain things, and you need to call a friend at times too.
Yeah, that's exactly
right. And that's
right.
just fine.
And teaching, this is a whole other conversation we can have about teaching them to work in teams, because that's the other aspect.
Correct.
Is we're no longer the solo practitioner. We have teams. We have PAs, NPs, nurses, physical therapists, social workers, pharmacists. We round as a team.
Absolutely. So what we're trying to think about as a board is exactly that. We're talking about the pipeline. We're talking about assessment of competency for cardiologists. What about team-based competency, right? You often will go to a clinician's office and perhaps see an associate provider, perhaps see a physician. It doesn't matter. At the end of the day, it's about how they are treating you as the patient.
Yeah.
And if we're responsible for the patient outcome, we need to change.
Well, and we have evidence that a pharmacist can take better care of your blood pressure, for example, at the population level than you or I can.
That's exactly right.
Because they have a specialized set of knowledge, they have a special set of tools, and they employ those in the care of managing the blood pressure for a population. Jeff, I could talk about this all day, and I'm sure my listeners would like to wrap it up. So I want to thank you for joining us here on Medscape Cardiology, taking some time out of your very busy schedule at the ACC. I'm hopeful that we can get you back in the years ahead to talk more about where thinking is evolving on how to train the cardiologists of the future. But I appreciate not just your time today, but for all you're doing for the profession. Thank you.
Thanks so much, Bob. It's been a pleasure.
For our listeners, if you enjoyed this discussion, take a moment to like, subscribe, or even write a review. It helps others. It certainly helps me as we think about your feedback, positive or negative. Give us suggestions. Tell us future topics to cover. We appreciate you listening, and I'm going to sign off now from Medscape Cardiology here at the Chicago ACC meetings.